Hello everyone. In this video, we are going to be talking about role, policy, leadership, quality improvement, and safety. So leadership. The nurse practitioner is educated to lead interdisciplinary treatment teams. It acts as a full partner in healthcare, designs, implements, evaluates, and advocates to redesign the U.S. healthcare system and translates research into practice. The team leadership model is based on multiple decisions. So decision 1, should the leader monitor the team or take action? They can seek out information to understand the team and analyze and interpret the information and decide how to act. Decision 2, should the leader intervene to meet the task or relational need? This is based on performance or task functions. And decision 3, should the leader intervene internally or externally? So access for conflicts between group members, such as the need for support or unclear goals, our action is to maintain group performance. We want to use reflective practice. Reflection uses a model or framework to systemically make sense of an experience. The process to tell a story about self and others to gain insight into practice enhances critical thinking to problem solve and enhance clinical reasoning and decision making. It links theory to practice, and it also uses debriefing strategies. So, for example, after a restraint, give feedback to improve practice after events. So this is when you debrief with your staff to see how things went, what you could improve on, how you can support them, and things like that. And sometimes they have a patient debrief as well to try to build that therapeutic connection with the patient and reduce the likelihood of a restraint happening again. So conflict resolution, negotiation, mediation, and professionalism. Conflict occurs when a person believes their needs, interests, or values are incompatible with others. To have conflict resolution, it has to be directed by a neutral third party who facilitates a win-win situation. There's a negotiation, which is the discussion among 2 or more people with the goal of reaching an agreement. Mediation is voluntary and confidential process in which a third party facilitates discussion to reach an agreement. Arbitration is the process in which a third party reviews evidence from both sides and makes a decision to settle the case. And professional civility is the behavior that shows respect towards another person. As nurse practitioners, we have to have critical thinking. We also know that we have to have critical thinking as a nurse as well. It's defined as the acquisition of knowledge with an attitude of deliberate inquiry, making clinical decisions based on evidence-based practice, decreases the difficulty of choosing from conflicting or multiple recommendations when diagnosing and treating clients, and develops self-awareness through metacognition process to gain new insight about self and in relation to others. So research consists of evidence-based practice. So this is the integration of the best research evidence with clinical expertise and client values and needs. Research utilization is a process of synthesizing and disseminating and using research-generated knowledge to make a change in practice, a subset of a broader evidence-based practice. And research utilization and evidence-based practice are 2 modes for reducing the gap between research findings and application to practice. A research utilization process starts with a critique of the research with a synthesis of the findings, then applying those findings, and then measuring the outcomes. So when we develop a clinical question, we use something called a PICO or PICO method. This stands for, P is for patient population or problem. So when we think of what is our target population, that is the P. Intervention is the I. So what is the intervention? This can be a treatment, diagnostic test, or procedure that we are applying. A comparison, is there a control group or comparison for the intervention? O is outcome. So what are the outcomes of the study? And T can be an optional measurement criteria, but this is the time. So what is the time frame for the study? What is the appropriate follow-up time to assess the outcomes? So there are levels of evidence. We always hear, people talking about research. Did you read this research? I've read the research. I know what I'm talking about. But here's the semi-problem with research, right? Not all studies are created equal. For example, if you have a very small control group, or you have a very small group in a study, right? That means that study is going to have low statistical significance, because if I have one of those 3 people that say no, right? Let's just say whatever I'm doing as a study, right? One person says no, 2 say yes. I could go and say, 66% of people say yes, but really that one person that said no could have been an outlier. So if I then went and interviewed 100 people, it still might only be that one person who has said no and everybody else has said yes. So really that study doesn't hold much weight because the statistics are not well supported, because I had such a small group, right? And, there's more examples of this. I think this pyramid does a really good job. So if we look at the top pyramid, we can see at the bottom, editorials or expert opinions. Expert opinions, they're great. People are experts in their fields and they have opinions, but really that doesn't hold much weight as far as evidence-based, right? Because it's their opinion. There's a risk for bias, and the quality of evidence is low. As we move up the pyramid, there's case reports and case studies, cross-sectional studies, case control studies, cohort studies, randomized controlled trials, but kind of the best research that holds a low risk of bias and a high quality of evidence is going to be systematic reviews and meta-analyses of randomized controlled trials. So what this means is that they take a bunch of randomized controlled trials and then they run research and statistics and things like that on that data from multiple. So that's going to hold a lot more kind of weight. But let's go through the levels of evidence. So level 1, evidence from systematic reviews or meta-analyses of all relevant randomized controlled trials or evidence-based clinical practice guidelines based on systemic reviews of randomized controlled trials and 3 or more randomized controlled trials of good quality that have similar results. A systematic review has a high level of overview of primary research on a particular question that identifies, selects, and synthesizes all relevant high-quality research. It requires rigorous, explicit protocols to appraise literature, excludes literature based on explicit criteria, and may include meta-analyses. A meta-analysis is a quantitative statistical analysis of several similar studies in which a sample compromises a pooled sample. It does not contain systematic reviews. So that's kind of at the top. That's our level 1 evidence. That is the best evidence. This is the research we really want to be translating into practice through our evidence-based practice. A level 2 evidence is evidence obtained from at least one well-designed randomized control trial. This is going to include like a large multi-site randomized control trial. Again, we talked about statistical significance. A small study doesn't hold much statistical significance, even if it is a randomized control trial. So you want to go with like the larger ones. That's going to be better. Level 3 evidence is obtained from well-designed controlled trials without random isolation, so a quasi-experimental design. Controlled clinical trials, participants are not randomly assigned to treatment or control group. So that's the difference between a randomized controlled trial and a controlled trial. So the random, the word random, right? People don't know if they're getting the treatment or they're not getting the treatment. They don't know what group they're in. And again, that's going to help give us more clear data. So level 4 evidence is from well-designed case control and cohort studies. Case control studies are observational studies that examine existing records to identify potential participants with a problem of interest who are compared to a similar group without the problem. There's no intervention in this type of study, and often it is a retrospective approach. There's a cohort study, which is another observational study of participants who share something in common and are observed prospectively for a phenomenon of interest. Often this can be done as a natural experiment. For example, nurses who work during the Northeast blackout are compared to those in the West Coast counterparts who work in similar situations. Cross-sectional studies are observational studies of participants without manipulating the study environment. For example, blood pressure measurements of people 25 to 35 years old on an SNRI. This type of study can compare different populations at a single point in time. This only provides a correlation information. And then a longitudinal study looks at a cross-sectional study repeated at various points in time. The environment is not manipulated and results are correlated, not causation. So level 5 evidence is from systematic reviews of descriptive and qualitative studies. So qualitative is like when we interview somebody, we might be having a conversation back and forth, and we might take certain aspects of that conversation and use that in our research. So in comparison to quantitative data, which is like numbers or using a Likert scale. A Likert scale is like a scale of numbers. So it will say like, how confident are you with managing patient aggression? And then 1, not very confident, 2, semi-confident, 3, like confident, 4, very confident, 5, exceptional, right? And then they would pick one of those numbers, and that allows us to calculate the data and run statistics on it. So that's quantitative. When we're talking about level 5 evidence, we're using qualitative. So again, those conversations, looking for patterns or things like that. And again, descriptive, very similar, right? Looking for descriptions, how people describe things. Level 6 is evidence from a single descriptive or qualitative study. So again, similar, right? This isn't a systemic review. This is one single study. We remember that a systematic review is looking at multiple studies. So for level 6 evidence, this can be things like a case study, so a deep analysis of an individual case or a particular phenomenon. A grounded theory, so a deep analysis of social and psychological processes that characterize an event or situation. Phenomenology, I'm not exactly sure how you say that, is a description of the structures of experiences as they occur to the conscious mind of an individual without deduction, assumption, or theoretical attributions. For example, the lived experience of siblings of people who are cancer survivors. Ethnography is a study of the meaning in a culture or community, for example, suffering in Amish women. And ahistorical is a systematic collection of objects, evaluation of data related to past event in order to hypothesize about causation, trends, implications on present and future events. And then level 7 evidence is from the opinion of authorities and or reports from expert opinions. All right, so again, this is an overview of everything we just went over with that evidence pyramid. This is just a really good kind of printout, kind of consolidates it all in one place. So just a nice slide. So there are different types of evidence, right? We talked about qualitative versus quantitative. So I like to think of quantitative like quantity. When we talk about quantity, we're talking about a number. And when we're talking about numbers, we can run statistics on those. So that's how I kind of remember the difference. But let's go a little bit deeper. So the focus of qualitative research, we're exploring ideas or formulating hypotheses and theories, whereas with quantitative research, we're testing hypotheses and theories. In qualitative research, the analysis is summarizing, categorizing, and interpreting, whereas with quantitative research, we're using math and statistical analyses. For qualitative research, it is expressed with words. So as we talked about, this could be like interviewing people, looking for patterns. Whereas in quantitative research, because we're dealing with numbers and statistics, we're going to see this with numbers, graphs, tables, and fewer words. When we have qualitative research, there's usually only a few participants because you would imagine interviewing a bunch of people takes a lot of time and work. Whereas with quantitative research, we can usually have a lot of respondents. In qualitative research, the questions are open-ended so that we can explore the ideas and what is being formulated. Whereas with quantitative research, because we want to run statistics, we need things to be cohesive. So we'll use close-ended questions or multiple choice or like those Likert scales. And qualitative research is characterized by understanding context, complexity, and subjectivity. Whereas quantitative research is testing, measuring objectively, and replicating, being able to replicate the study after. So in interpreting research findings, we have to clearly understand key terms that allows one to understand the implications and limitations of the research finding. It is essential to know the question the research is designed to answer, and more specifically, what is being measured, which are the variables. Variables are what we measure. The primary aim is to understand cause and effect relationship with a known degree of certainty. So you're going to have the dependent variable. So let's remember the variables are the things we measure. A dependent variable is the effect. So this is the factor that changes as a result of the independent variable. So which makes sense, right? Because if you're dependent, you're relying on something. So the dependent variable is relying on the independent variable. The independent variable is the cause. So this is our intervention intended to cause a change. Nursing research should have evidence from at least one well-designed randomized controlled trial, make an evidence-based decision regarding implementation, implement the change depending on the above decision, and dissemination, meaning that nurse practitioners should present at local, regional, and national conferences. We should try to publish in peer-reviewed journals or professional newsletters. And reliability is an important component of research. It is the consistency of a tool to measure adequately over time, test and retest across items, which is internal consistency across different researchers, so interrated. So when you when you decide to conduct research, typically, especially if you're doing a quantitative study, you're going to need to use a tool to measure whatever it is that you're studying. Like, are you looking to, I'm just thinking of like my research project, if you're looking to increase confidence of healthcare workers in managing patient aggression, you need to have a tool with good reliability in order to measure the changes in confidence level pre and post whatever your intervention is, say an educational thing. This was my capstone project, so I'm just giving that example. You don't want to just make up a tool, right? Because that doesn't have a lot of reliability. It's never been used before. We don't know if it's going to work, right? You want to find something that's already created and use that because it's reliable. It's been used, and they will run, I believe it's called Chromebacks Alpha, which will show its reliability essentially. So internal validity. This is the independent variable caused a change in the dependent variable. Things that can threaten internal validity within a study is extraneous variables that may compete with the internal validity, a confounding variable, so an extraneous variable that does affect the dependent variable, history, so an unanticipated event that occurs during the experiment, Maturation, so did a normal process over time lead to the effect? Regression, a phenomenon describing the tendency of extreme scores to regress to the mean on subsequent tests, usually due to decreased reliability in the measuring tool. Selection bias, so when groups are not equal at the beginning of the study, so say they're self-selected or not randomly assigned or randomly selected participants. We want them to be randomly selected. If they're not, we're losing that internal validity. Mortality refers to the dropouts among the research. Testing, so pre-test influences on post-test results. Contamination, so when a control group discovers something about the experimental group or when participants desire a specific outcome, rivalry can develop between groups and resentful demoralization develops between groups. In instrumentation, so a change that happens in applying the tool or test, for example, different instructions by different research assistants, duration to give instruction, tone of voice, specific details might be included or omitted, so this can all affect that internal validity. External validity is when the sample is representative of the population and the results can be generalized. So if our sample set of people are not representative of the population, we cannot say that our results can be generalized, right? Let's say you have all white males in your study. You can't say that in the general population XYZ because your study only focused on a specific type of person, right? So this is why in research, we want to look at gender identification, race, age. You can even go a little bit deeper to like educational level, socioeconomic status if you wanted, like income level, things like that. That's going to give us that external validity. So threats to external validity. So again, the degree to which the sample represents the population at large. If it doesn't, we just went over that. The setting. So how similar is the setting of the experiment to the general settings? There can be an interaction effect between test settings and outcomes, which is a dependent variable. For example, a pre-test cues the participant to behave in a certain way. We can have a multiple treatment effect where interactions between multiple treatments are independent variables on an outcome, the dependent variable. For example, when the same subject receives 2 or more treatments in a repeated measured test, it can trigger a carryover effect in subsequent measures. And a reactive effort when a participant acts in a certain way merely because they're in the study. This is called the Hawthorne effect. So when we talk about reliability and validity, this is a nice chart. So if we look at the top left, we can see that this study or this target is unreliable and unvalid because it's kind of all over the place up at the top, right? But it's only on one side of the target. Whereas if we look at the one next to it, it is unreliable but valid. So we're not hitting the target. It's not reliable, right? It's not hitting in the same spot over and over again. That would be something that's reliable. Like even if it wasn't hitting on the target, it'd still be reliable because it's hitting in the same spot. But this one isn't. It's all over the place. So it's unreliable, but it is valid because time and time again, it's hitting all over the place. Whereas if we look in the bottom left, this one is reliable. It's hitting the same spot over and over again, but it's not valid because it's just in one set corner of the target. And then the last one, if you hit on the bullseye, it is reliable and valid because it is hitting that center target over and over again, and it is hitting the target, which is an equal part of all 4 quadrants. All right, so interpreting research, descriptive statistics. So these are used to describe the basic features of the data in the study. So numerical values that summarize, organize, and describe observations can be generated by either quantitative or qualitative studies. So when we're looking at descriptive statistics, we're looking at the mean, which is the average of scores. This is when you add all of the scores together and then divide by the number of scores that there are, and that is your mean. There is a standard deviation, which indicates of the possible deviations from the mean. Then there is also a variance, so how the values are dispersed around the mean. The larger the variance, the larger the dispersion of scores. Then there's also inferential statistics. So this is a numerical value that enables one to reach a conclusion that extends beyond the immediate data alone, and it is generated by quantitative research designs. So some examples include a t-test. This assesses whether the means of two groups are statistically different from each other. Then there is an analysis of variance, or an ANOVA test. This tests the difference among three or more groups. There's an analysis of covariance, which is a general linear model combining regression analysis and ANOVA. There's something called Pearson's R correlation, which tests the relationship between two variables. There's probability, which is the likelihood of an event occurring. It lies between 0 and 1. An impossible event has a probability of 0, and a certain event has a probability of 1. So 1 is the highest you can get. A p-value, also known as the level of significance, describes the probability of a particular result occurring by chance alone. And then a regression analysis is a statistical method that allows the examination of relationships between two or more variables. There's also a factor analysis. So this is a statistical method that is used to describe variability among observed correlated variables with respect to fewer unobserved variables. So the observation noted in 8 variables may mainly reflect the variation between 2 unobserved variables. There's a multi-dimensional scale, so a mean of visualizing the level of similarity of individual causes of data in a set in a distant matrix. There's a cluster analysis, so the task of grouping in such a way that similarities within the group are more common than between groups, and correlations is a mutual relationship between 2 or more variables. So there is ethical considerations of research. So when you're conducting research, you have to get institutional review board approval. This ensures that risks to participants are minimized, that the selection is equal, that adverse events are reported and risks and benefits are reevaluated, informed consent is obtained and documented, data and safety monitoring plans are implemented. Overall, it really focuses on the rights and well-being of human research participants and that they're protected. It will let researchers know if they have to modify or if there's any disapproval of their research activity. And all investigators or people involved in the research must take and pass a test on the protection of human subjects. So quality improvement is agency-specific projects that aim to improve systems and decrease cost and improve productivity. It provides a standardized method to identify gaps in practice and systems to evaluate ways to improve the structure, function, and resources in healthcare delivery within complex health systems. It protects projects designed to improve systems, decrease costs, and improve productivity, for example, a retrospective chart review. And the Institute of Medicine's quality aims is for safe, effective, client-centered, timely, efficient, and equitable care. And it is also used to examine internal processes. So new knowledge is specific to an organization. And there's a Donabedian model, which focuses on the structure, process, and outcome. This uses tools like risk management, a process used to identify potential dangers in practice due to adverse patient outcomes, focusing primarily on system errors and passive safety measures. They also use Centile event reporting, which triggers a root cause analysis for unexpected adverse outcomes that are reportable to health officials and regulating boards with public protection. A root cause analysis aims to identify all of the contributing factors that resulted because of this sentinel event, such as inpatient suicides, unanticipated deaths, sexual assaults of a staff member, visitor, or vendor, improper procedure on the wrong patient or the wrong procedure, unintentional retained objects, or fire or unanticipated environmental hazards in patient care areas. So when we do quality improvement projects within our institution, we use we use a process called a PDSA cycle. This stands for a Plan, Do, Study, Act. So plan is planning the change. To do this, we're going to set improvement goals, predict what is going to happen, plan the cycle, who, what, where, and how, and decide what to do or gather. Then we're going to do, where we carry out the plan, document the problems, and gather data. Then we're going to study, where we examine the results, analyze them, compare data predictions, and examine learning. And then we're going to act, where we decide what actions will improve the process, adopt, adapt, or abandon the cycle. And if adopting with no change, we roll out the improvement. And when we're translating research into practice, we want to use quality improvement efforts and clinical inquiry to lead to improved systems and processes, which create improved health outcomes. So a root cause analysis is defined as a collective term that describes a wide range of approaches, tools, and techniques used to uncover the causes of a problem. There are failure modes and effects analysis, which is a systematic, proactive method for evaluating a process to identify where and how it might fail and to assess the relative impact on different failures in order to identify the parts of the process that are most in need of change. Core competencies are the ability to practice nursing that meets the needs of the client's care by using logical thinking and accurate nursing skills. A forced field analysis, it looks at forces that are either driving movement towards the goal, which are the helping forces, or blocking movement, which hinder these forces. And then a risk analysis, it's important for an ongoing process that should provide an organization with a detailed understanding of its risks and information necessary to address the risks in a timely manner. So a conflict of interest, so a person's financial, professional, or personal situations may affect a person's judgment in his or her professional responsibilities, so we must disclose if we have any potential conflicts of interest, at least annually, or whenever new significant financial interests are received. Disclosure must be reported to employers, boards, professional agencies, and wherever there is potential for a conflict of interest, actions should be carried out to resolve potential or actual conflicts of interest and reduce biases. And healthcare agencies and educational and research institutions have policies to require the disclosure of any potential conflict of interest and to define the limits allowed in any relationship within external organizations and companies. A conflict of interest form indicates any financial or other relationship with the products being discussed must be completed prior to any professional presentation. Types of conflict of interest include relationships with pharmaceutical, medical supplier, insurance companies, money or gifts of any kind, referrals, or fee splitting. So kind of shifting gears, culture is a very important aspect to our care as nurse practitioners. We have to follow evidence-based guidelines, are always client goal directed, and take into account the client's ethnicity and culture. A key part of our work is to use empirical evidence in educating clients, their families, and the community about mental health, psychiatric illness, and the management of the illness. We use this to reduce stigma, and we want to target more people and choose answers that target more people, and stigma can present as shame. Cultural expected responses to a stressor does not mean someone has a mental illness. We have to keep that in mind. If a patient presents with a symptom that could be a cultural response, ask them what the behavior means to them. This is a big one. That's probably something you will see on the exam. Ask the content or meaning and respect. So, different cultures have different beliefs that if they weren't part of their culture, we might think like, oh, they're psychotic because they keep talking about the evil eye or something like that, right? But no, that's just their culture and something that they use to talk about a specific situation. So we want to ask them about that. Like, what does the evil eye mean to you? What does this mean in your culture? And things like that. So we can, get to the bottom of it. So just culture of safety. So American Nurse Association position statement supports the collaboration efforts among state boards of nursing professional organizations, patient safety centers, and health systems to develop a just culture initiative. This holds people accountable for their behaviors and investigates errors. The goal is to create an open and fair learning environment to design safe systems and manage choices. In a just culture, individuals are continually learning, designing safe systems, and managing behavioral choices. Mindset that affects work environment to proactively look for system breaks and identify ways to improve the systems. And it creates an environment that encourages individuals to report mistakes so that the precursors to errors can be better understood. So really, creating an environment of just culture lets people feel safe to report when they make an error. And that way we can figure out why they made this error. Was there some sort of system that could have been put in place to prevent this, so that we can reduce it from happening in the future. Health delivery system. So healthcare is complex and fragmented. Focus is on the interaction of the parts of the relationship, and it is a nonlinear process. Access to care is client-centered, and care models are based on the principle that healthcare services should be coordinated and directed by a single physician or other provider. In this model, clients can access services from multiple entry points. Services can be located in the same facility or an integrated care network of providers in different locations and can be accessed when needed. The National Committee for Quality Assurance developed 11 health effective data information sets. So these include antidepressant medication management, follow-up care for children prescribed ADHD meds, follow-up hospitalization for mental illness, diabetes screens in those with schizophrenia and bipolar disorder who are on antipsychotics, diabetes monitoring for people with diabetes and schizophrenia, cardiovascular monitoring for people with cardiovascular disease and schizophrenia, adherence to antipsychotic meds in individuals with schizophrenia, the use of multiple concurrent antipsychotics in children and adolescents, metabolic monitoring in children and adolescents on antipsychotic meds, and the use of first-line psychosocial care for children and adolescents on antipsychotic meds, and mental health utilization. Organizations of practice. So with the Affordable Care Act, practices are being reorganized and redesigned to provide integrative care, including medical and psychiatric care. The client-centered medical home has support of the health resources and service administration and initiatives to provide client-centered, evidence-based, coordinated, and quality care moving forward. The patient-centered care model is a welcoming environment provided by a physical space and an initial personal interaction that is welcoming and familiar and not intimidating. There needs to be respect for the client's values and their needs. We want to obtain information about their preferences and priorities, inform and involve their family and caregivers in decision-making, and tailor the care to the person, promoting a mutual respect. We want a client-empowered or activation. So we want to educate and encourage the client to expand his or her role in decision-making, health-related behaviors, and self-management. We also want to have socio-cultural competencies, so understanding and considering culture, economic and educational status, health literacy, family patterns, situations, and traditions, communicating in a language and at the level that a client understands. So this means that if a client, English is not their first language, we should use an interpreter. If the client speaks English but speaks another language and prefers their care to be in the other language, we have to use an interpreter. Coordinating and integrating of care, assessing their needs for formal and informal services, management referrals as needed, advocating for them and ensuring a smooth transition between providers, and offer comfort and support, both emotional and physical comfort, involving family and friends. Access and navigation skills, so providing what the patient can consider a medical home, keeping waiting times to a minimum, providing convenient service hours, promoting access and client workflow, and helping the client to obtain skills to navigate the healthcare system. And community outreach, making demonstrative, proactive efforts to understand and reach out within the local community. Also using familiarity with the leading cause of death, immunizations, prevention strategies, and routine screenings based on age and stages allows nurse practitioners to provide anticipatory guidance to their clients. When we talk about screenings, so it depends on the age and stage. So when we talk about specificity, this is a degree of confidence in a test for a particular condition or trait. It looks for a true negative, which is a rule out disease. It is a very specific test will rule out a disease with a high degree of confidence. For example, troponin found to be greater than 2, specificity is 91%. However, when troponin is 0.6, specificity is 81%. Then when we talk about sensitivity, this is a degree of confidence in a test to detect true positives. Example, when troponin is found to be greater than 2, sensitivity is 85. However, if troponin is 0.6, sensitivity is 94. So again, sensitivity is confidence of testing true positives, where specificity is the degree of confidence in testing true negatives. So a screening test should be sufficiently sensitive to justify specifically testing for confirmation. So there are levels of prevention. So the first, and this will definitely be on the exam most likely, the first is primary. So healthy people are provided general advice, balanced diets, seatbelts, exercise helmets, regulations against drunk driving, workplace measures, environmental protection, general measures for mental health. So I like to think of primary as prevention. Anytime we are doing something to prevent a disease or condition from happening, this is a primary level of prevention. Then when we talk about secondary, this is when we look for a disease in a group. So blood pressure screens, mental health screens, sexually transmitted infections screens, long-acting injectables to prevent the reoccurrence of psychosis symptoms or taking a medication. So secondary, I like to think of as either a screen or as like taking, a medication that is something like a long acting, it's kind of reducing it from happening in the future. And then tertiary is reducing disease progression in one who is diagnosed, often after acute treatment and stabilization. So this is going to be things like drug alcohol rehab, support groups, therapy, psychoeducation. So this is the treatment. Healthcare at home, so defined in the Affordable Care Act, is an approach to primary care that provides coordinated care to persons with multiple chronic health conditions, offers team-based care, and builds on community supports. All right, so that is the end of this one. I will say, just to go back for this, for purposes of the test, all you have to remember is primary is to prevent, secondary is to screen, and tertiary is to treat. Just stick to that. Don't get too caught up in the long-acting injectables and things like that. All right, I will see you guys next time. Thanks. Bye.